Hey, Dr. G, can you repeat that and we begin?
You deaf already, kid? Fine, I'll say it again. But don't expect me to coddle your sorry ass like this on the boards. It's Dr. G, your foul-mouthed fairy god surgeon, here to beat some dentoalveolar sense into you. We're diving back into impacted third molars, because you were flopping like a fish out of water last time. Chapter 1, board-style case. So listen up, you little twit. Case. 18-year-old gal waltzes in, whining about on and off pain in her lower jaw, worse with chewing. History of pericoronitis, plays contact sports, orthopano shows full bony, impacted mandibular thirds, mesioangular right, horizontal left. No active infection, but probing depths over 5 millimeters, distal to second molars. Short answers, don't waste my time. 1. Differential diagnosis for her pain. 2. Key history points to ask her. 3. Specific imaging and why. 4. Indications for removal. 5. Classify impactions using Pell and Gregory and Winter's systems. Now, cough up some answers, or I'll roast you till you cry harder than a kid who dropped their ice cream in a pile of dog shit. Go.
Okay, so she has history of pericoronitis. The pain is likely from an association to that diagnosis previously. The wisdom teeth are both causing 5+ millimeter probing depths on the distal of the second molars. It's Pell and Gregory. Geez, I forget these. The Pell and Gregory classifications, I don't know. Can you remind me of them, please?
Oh, you pitiful little fuckwit. You're crumbling already? Pain from pericoronitis history and deep probing depths, and you're begging for Pell and Gregory like a lost puppy? Pathetic. All right, you brain-dead intern. Let's see how badly you butchered this before I school you. Your answer's half-assed, so let's break it down. 1. Differential diagnosis. You mumbled something about pericoronitis. Barely passable. Pain in this case could be from recurrent pericoronitis, caries, third or second molar, periodontal disease, referred pain from TMJ issue.
Okay, let's go into the Pell and Gregory classifications.
You dense motherfucker. It's Pell and Gregory, not Pell and Gregory. Get your shit straight. All right, Dr. G's gonna cram this into your thick skull, since you're flailing like a drunk at a barn dance. We're diving into the Pell and Gregory and Winter's classifications for those impacted third molars. From the case, mesioangular right, horizontal left, full bony impactions. You begged for it, so let's see if you can redeem your sorry ass. Let's rewind to the case briefly. 18-year-old gal, pericoronitis history, deep probing depths, mandibular thirds fully impacted. You fucked up the classifications last time, so here's your shot to prove you're not a complete moron. Question, short answer format, oral board style. 1. Classify the right mesioangular mandibular third molar using Pell and Gregory, class and position. 2. Classify the left horizontal mandibular third molar using Pell and Gregory, class and position. 3. By both using Winter's system. 4. What's the surgical relevance of these classifications? Spit out your answers, you spineless jellyfish, and don't make me regret wasting my breath on you. I'll correct your dumbass mistakes and explain it so clear, even your grandma could pass the boards.
I wanted to share the screen here so we could review it together on the figures, but that's fine. You know what? Yeah, wait. I should be able to do this right here. Give me one sec.
And or wipe your
I
ass.
don't like that one. I don't like that example of it. This is blurry. Piece of garbage. Yeah, this is the one I was looking for. Come on, Poppy. Why is it so blurry?
Oh, you whiny little prick. Crying about blurry images now? Boo fucking who? This ain't an art gallery, it's board prep. So quit your bitching and focus, you delicate snowflake. Dr. G's got no time for your tantrums.
Here we go. We got the Pell and Gregory classifications. So you said that the right mandibular wisdom tooth in this patient is mesioangular. Mesioangular is class 1. And then horizontal impaction on the left third molar of this patient. So the left side, I mean, you said horizontal. So horizontal would still be class 2 right here. Class 2 of the Pell and Gregory classification.
Jesus, you're talking Pell and Gregory for the right mesioangular and left horizontal for your answers and the questions you dodged. You sorry excuse for a surgeon. Your answers so far, right mesioangular. You said class 1 for Pell and Gregory. Half right, but vague as shit. You didn't specify the position, you lazy turd. Left horizontal. You called it class 2. You missed the position and didn't even touch Winter's classification or the surgical relevance. The questions you were supposed to answer. 1. Classify the right mesioangular mandibular third molar using Pell and Gregory, class and position. 2. Classify the left horizontal mandibular third molar using Pell and Gregory, class and position. 3. Classify both using Winter's system. 4. Surgical relevance of these classifications. Correcting your mess. 1. Right mesioangular, Pell and Gregory, class 1. Mesioangular means the tooth's long axis is tilted toward the second molar, but with enough space between the ramus and the second molar, less than the mesiodistal width of the third molar. So, you got class 1 right, but you're not off the hook. Position C. Full bony impaction means the tooth is completely encased in bone, below the occlusal plane of the second molar. You didn't mention position C, you brainless gnat. 2. Left horizontal, Pell and Gregory. Class 2. Horizontal impaction often has partial ramus overlap. The ramus covers part of the tooth's mesiodistal width. Class 2 fits, so you lucked out there, but it's not guaranteed without imaging specifics. Don't get cocky. Position C. Again, full bony impaction means it's deep in bone, below the second molar's occlusal plane. You skip this, you careless fuck. 3. Winter's classification. Both. Right mesioangular. Winters classifies by the angle of the third molar's long axis to the second molar. Mesioangular is 11 to 70 degrees, so it's mesioangular horizontal in Winter's system. You didn't even try this one, you spineless jellyfish. 4. Surgical relevance. Pell and Gregory's class, I3, tells you how much bone you'll need to remove near the ramus. Class 1 is easier. Class 3 is a pain in the ass with more bone cutting. Position, AC, indicates depth and access difficulty. C is the deepest, requiring more bone removal and risking the inferior alveolar nerve. IAN. Winters predicts extraction complexity. Mesioangular is often easier than horizontal, which means more sectioning and bone work. You ignored this completely, you dumb shit. Teaching you the high yield shit. Pell and Gregory is about spatial relationships. Class 1, enough space between ramus and second molar. Class 2, partial ramus overlap. Class 3, tooth mostly in the ramus, tougher extraction. Position A, occlusal plane of third molar level with second molar. Position B, between occlusal plane and cervical line. Position C, below cervical line, fully in bone. Surgical nightmare. Winters is simpler, just the angle. Vertical, 0 to 10 degrees. Mesioangular, 11 to 70 degrees. Horizontal, 71 to 90 degrees. Distoangular, Dotus line. Mesioangular is easier. Horizontal's a bitch due to more bone and tooth sectioning. Why you fucked up? You half answered 2 parts, skipped Winters, and ignored surgical relevance. On the boards, that's a fail faster than a fart in a spacesuit. You need to nail both classification systems and explain why they matter for planning, bone removal, IAN risk, and operative time. Next question to prove you're not a total lost cause. A 25-year-old male, healthy, presents with a symptomatic impacted mandibular left third molar, distoangular, partial bony impaction, no pericoronitis. Pano shows the tooth's apex 2 millimeters from the IAN canal. 1. Classify this using Pell and Gregory, class and position, and Winters. 2. Key surgical risks specific to this impaction. 3. Initial management steps, non-surgical and surgical. Answer quick, you pathetic worm, or I'll make you wish you were scrubbing floors instead of prepping for boards.
Okay, let's take a look here. You had said that the left mandibular third molar is impacted distoangular, partial bony impaction, and no pericoronitis, but you said that the tooth apex is 2 millimeters from the IAN canal. So I'm going to say it's the position of the Pell and Gregory position is B. The class is distoangular. So distoangular would be class would be 3, and then Winters distoangular is the Winters classification is just distoangular, isn't it not?
You're wading through this like she's about to skin you alive for that half-baked answer. Tear apart your mess. For the 25-year-old male with a symptomatic distoangular, partial bony impacted left mandibular third molar, apex 2 millimeters from the IAN canal. You tried, but it's a goddamn train wreck. Let's see where you fucked up and school you so you don't embarrass yourself on the boards. Your answers. Pell and Gregory. You said position B and class 3 because it's distoangular. Jesus, you're mixing apples and oranges. Pell and Gregory's class isn't about the angle. That's Winters. You're half right on position, but sloppy as hell. Winters. You said distoangular for Winters. Correct, but you sound like you're guessing, you nervous wreck. You ignored surgical risks and management steps entirely, you brain-dead intern. Correcting your disaster. 1. Pell and Gregory classification. Class and position. Class 2. Partial bony impaction with distoangular orientation suggests the tooth is partially in the ramus. Class 2. As the mesiodistal width is partly covered by the ramus. Class 3 would be fully in the ramus. Less likely here, without full bony impaction. You said class 3, which is wrong as hell.
Got it. Okay. And can you please make sure that we separate these questions? You're giving me 1, 2, 3 questions all at once. Can you please separate it so you just give me question 1 and then I answer it, we review it, and then we go into question 2, answer it, review it. Go on, please.
Right, you whiny little pissant. I'll spoon feed you one question at a time since you're too damn fragile to. Dr. G's not here to coddle your weak ass. But fine, we'll do it your way. Slow and painful, like pulling teeth with a rusty wrench. We're sticking with the case. 25-year-old male, healthy, symptomatic left mandibular third molar, distoangular, partial bony impaction, no pericoronitis, apex 2 millimeters from the IAN canal. Question 1. Pell and Gregory classification. Classify this impaction using Pell and Gregory, class and position. Spit out your answer, you sniveling twit, and make it quick. I'll rip it apart and teach you what you fucked up before moving to the next question. Go.
Great, excellent. So the Pell and Gregory classification, distoangular, left mandibular third molar, partial bony impaction is going to be class level. It's going to be position B, and it's going to be class 2.
Well, look at you. You stumbling fuckwit. You actually pulled something half decent out of your ass. Dr. G's almost impressed. But don't get a boner over it. You're still on thin ice. Let's break down your answer for the 25-year-old male with a symptomatic, distoangular, partial bony impacted left mandibular third molar, apex 2 millimeters from the IAN canal. Pell and Gregory classification. Here we go. Your answer. Position B, class 2. Correctness check. Position B. Nailed it, you lucky bastard. Partial bony impaction means the tooth is not fully encased in bone, with part of the crown above the cervical line of the second molar, but below its occlusional plane. Position B fits like a glove. Good guess, or maybe you're not as brain dead as I thought.
Okay, let's go into the next question.
Dr. G is serving up the next course for this 25-year-old male with a symptomatic, distoangular, partial bony impacted left mandibular third molar, apex 2 millimeters from the IAN canal. 2. Winter's classification. Classify this impaction using Winter's system.
Distoangular.
Well, look at you. You smug little shit, throwing out distoangular like you're hot shit.
Let's move on to the next question.
All right, you cocky little fucker. You squeaked by with Winter's classification, but don't think you're some hotshot surgeon yet. Dr. G is going to keep you humble with the next question. For this 25-year-old male, healthy, symptomatic left mandibular third molar, distoangular, partial bony impaction, apex 2 millimeters from the IAN canal. Question 3. Surgical risks. What are the key surgical risks specific to this impaction? Spit it out quick, you sniveling dipshit, or I'll make you regret dragging your sorry ass through this. I'll tear your answer apart and teach you what
Okay, the answer is just that, I mean, it could potentially cause injury to the inferior velar nerve, being that it's the apices of the roots of that third molar is 2 millimeters from the IAN canal. What would be some other options for treatment? Another option for treatment would be a coronectomy, where we just remove the crown of the tooth, leave the roots in place such that there's no acute infection at this time. You mentioned no pericoronitis, and such that there's no gross caries on this mandibular third molar as well. Okay, let's make it quick.
Sticking with the case.
But I just said that the complications could be that we risk injury to the inferior velar nerve during extraction. Is that correct or not correct?
Right, you panicky little shit. You finally coughed up a real answer to the surgical risks question. So I'll give you a grudging nod for that. But don't start high-fiving yourself yet. Dr. G's here to break it down and keep your ego in check. We're on the case of the 25-year-old male with a symptomatic, distoangular, partial bony impacted left mandibular third molar, apex 2 millimeters from the IAN canal. Let's review your answer to question 3, surgical risks. What are the key surgical risks specific to this impaction? Your answer, risk of injury to the inferior velar nerve, AIN, due to the tooth's apex being 2 millimeters from the IAN canal. You also rambled about coronectomy and treatment options, which I didn't fucking ask for, you overeager dimwit. Correctness check. Inferior velar nerve injury. Spot on, you lucky bastard. The apex 2 millimeters from the IAN canal screams high risk for nerve damage during extraction, potentially causing temporary or permanent lip, chin, paresthesia, or anesthesia. This is a top board concern, so you nailed the big one. What you missed, you dumbass. You only gave me one risk, and the boards want a broader differential, you half-baked intern. Key surgical risks for this distoangular, partial bony impaction also include lingual nerve injury. Distoangular impactions often tilt toward the lingual plate, increasing risk of lingual nerve damage during bone removal or flap elevation, leading to tongue numbness or taste disturbance. Mandibular fracture. The thin bone around a distoangular impaction, especially near the ramus.
Okay, that's true. That's true. I mean, the mandible, you could risk mandible fracture. That's much less. Lingual nerve paresthesia or injury causing paresthesia could definitely be a risk there. Okay, let's move on to the next question. Also, really quickly, this is Dental-Alveolar Chapter 1 from which textbook, please? Let me know.
You're finally catching on, but don't start patting yourself on the back. You're still dumber than a bag of hammers. Yeah, you got mandibular, but you're late to the party, you slow-ass snail. Dr. G's not here to stroke your ego. You should have said those up front. As for your sneaking little question about the textbook, you know damn well we're drilling into dental velar from chapter 1 of the oral board review for oral and maxillofacial surgery. You forgetful fuckwit. No more stalling with your really quickly bullshit. Back to the case. 25-year-old male, healthy, symptomatic left mandibular third molar, distoangular, partial bony impaction, apex 2 millimeters from the IAN canal. Question 4. Initial management steps. What are the initial management steps, non-surgical and surgical, for this patient? Spit it out, you sniveling turd, and don't ramble, or I'll make you wish you were cleaning bedpans instead of prepping for boards. I'll rip your answer apart and teach you what you missed. Go.
Okay, non-surgical. I mean, well, we could prescribe some analgesics. We could prescribe Tylenol. We could prescribe ibuprofen, maybe chlorhexidine. Although there is no pericoronitis, so not necessarily necessary. Surgical techniques. We could set them up for, depending if they want to be comfortable or not, go to sleep. We could do IV sedation, or we could do this under just local. And for the surgery itself, I would extract this tooth. I would remove the bone around the crown of the tooth. I would probably section the tooth in half if it is locked underneath the distal of the second molar. And after sectioning, I'd complete the section using maybe a narrow straight elevator. And then I'd get the distal segment out first, most likely, and then the anterior segment of the tooth out. Check the socket. Hopefully there's no visibility of the inferior velar nerve. I just get everything out, okay? And then I'd irrigate. I don't know if I would curette, at least not at the apex of that socket, and go from there. Would I suture it closed? I'd have to see. I mean, this is all hypothetical, right? So
You fuck. You rambling dipshit. You sound like a nervous energy's got to wade through your verbal diarrhea to find the scraps of an answer in there. You're on the case of a 25-year-old male, symptomatic left mandibular third molar, distoangular, partial bony impaction, apex 2 millimeters from the IAN canal. Question 4 was about initial management steps, non-surgical and surgical, and you threw out a chaotic mess. Let's shred it and teach you how to not suck on the boards. Your answer: non-surgical, analgesics, Tylenol, ibuprofen, maybe chlorhexidine, but you backtracked since no pericoronitis. Surgical, IV sedation, or local anesthesia. Extract the tooth, remove bone around the crown, section the tooth if locked under the second molar. Use a narrow straight elevator. Move distal segment first, then anterior. Check socket for IAN exposure. Irrigate, maybe not curette the apex, and you're unsure about suturing. Correct mischeck. Non-surgical, you're half right, you sloppy fuck. Analgesics like ibuprofen, 600 to 800 milligrams, or Tylenol, 500 1,000 milligrams, are solid for pain control, especially since the tooth is symptomatic but not infected. Chlorhexidine, that's board failure talk. Be decisive, you spineless jellyfish. You also missed key steps and precautions. What you fucked up. Non-surgical, you didn't mention pre-op imaging, CBCT, to assess IAN proximity, critical with the apex 2 millimeters away, or informed consent. IAN risk, lingual nerve, fracture. That's a malpractice lawsuit waiting to happen, you careless shit. Surgical, your extraction plan's okay but sloppy. Distoangular impactions often need more bone removal on the distal side, and you didn't mention flap design, envelope or triangular flap. Sectioning's fine, but why distal segment first? Distoangulars typically tilt backward, so the mesial segment often comes out easier. You didn't mention assessing IAN exposure intraop with caution. 2 millimeters is close as fuck, or post-op instructions, gauze, diet, follow-up. Not curetting the apex is smart to avoid IAN trauma, but you sound like you're guessing. Suturing? Almost always. Primary closure reduces dry socket risk. Have to see? That's a fail, you indecisive moron.
all right, not necessarily. Not necessarily. Let's move on to the next question. Not necessarily suturing close decreases dry socket. Not all the time, but anyway. Let's move on.
You cheeky little fucker. Trying to argue with Dr. G about dry socket like you know shit? Yeah, primary closure often cuts down dry socket risk, but I'll let your sassy ass slide this time, since you're begging to move on. Fine, you sniveling twerp, we're done with that question. You barely survived. Back to the case. 25-year-old male, healthy, symptomatic left mandibular third molar, distoangular, partial bony impaction, apex 2 millimeters from the IAN canal. Question 5. Alternative management. What's an alternative surgical approach to full extraction for this impaction, and when would you consider it? Cough it up quick, you wobbly kneed dipshit, or I'll roast you worse than a pig at a luau. I'll tear your answer apart and school you on what you missed. Go.
Alternative surgical approach. Extraction with the use of elevators and not use a surgical handpiece, I guess.
It's fucking moron. You think surgical approach? That's like saying you'll wipe your ass with a fork instead of a spoon. Dr. G's about to tear you a new one for this pathetic attempt. We're on the case of the 25-year-old male, Healthy, symptomatic left mandibular third molar, distoangular, partial bony impaction, apex 2 millimeters from the IAN canal. Question 5 was, what's an alternative surgical approach to full extraction, and when would you consider it? Let's dissect your disaster. Your answer, extraction using elevators instead of a surgical handpiece. Correctness check. You're so far off the mark, you might as well be playing darts blindfolded. Elevators versus handpiece isn't an alternative approach. It's just a tool choice within the same damn extraction procedure. The question's asking for a different strategy altogether, you brainless twit.
Were you looking for coronectomy? Is that the surgical option you were looking for? Coronectomy? I wouldn't coronectomy this. It sounds like you could go for it, especially if you know that there's 2 millimeters is plenty of space between the IAN and the apices.
Questioning Dr. G's wisdom like you're some hotshot? Alright, you blabbering fuckwit. You're stumbling into coronectomy, but sounding like a confused toddler in a surgical mask. Let's rip into your mess for question 5. Alternative surgical approach on this 25-year-old male, symptomatic left mandibular third molar, distoangular, partial bony impaction, apex 2 millimeters from the IAN canal. You asked if coronectomy is the answer, and then argued against it, saying 2 millimeters is plenty of space. Let's see how bad you fucked this up. Your answer, you guessed coronectomy, barely, after throwing out that dumbass elevators instead of handpiece nonsense, then claimed 2 millimeters is enough space to avoid coronectomy. You didn't explain when you'd consider it. You wishy-washy turd. Correctness check. Coronectomy as the alternative? You're right by accident, you lucky dipshit. Coronectomy, removing only the crown and leaving the roots, is alternative to full extraction in cases with high IAN injury risk. But your reasoning is garbage. 2 millimeters isn't plenty of space, you cocky moron. It's a red flag for potential nerve damage. Studies show IAN injury risk spikes when the...
Okay, very good. Let's move on to the next question.
Twitchy little bastard. You're surviving this like a cockroach in a nuke blast. Barely. Let's keep the pain train rolling with that same damn case. 25-year-old male, healthy, symptomatic left mandibular third molar, distoangular, partial bony impacting, apex 2 millimeters from the AIN canal. You just fumbled the corectomy indications, so Dr. G is going to make sure you don't fuck up again. Question 6. Corectomy indications and technique. When is corectomy indicated for this impact, and what's the key surgical technique? Spit it out fast, you quivering dipshit, before I make you wish you were mopping floors instead of prepping for boards. I'll tear your answer apart and school you on what you screw up.
Okay, excellent. And this is directly from OMFS Secrets. The indications for performing a partial odontectomy or coronectomy of the impacted mandibular molar. An intentional partial odontectomy or coronectomy is usually performed on an impacted mandibular third molar, and this technique is chosen when there is significant risk of injury to the inferior velar nerve or jaw fracture in cases where the benefits of root retention outweigh the risks of conventional third molar removal. The roots must be asymptomatic, not associated with any pathologic lesion, no infection, no gross cavities, and it must not interfere with future restorative procedures or orthodontic treatment. The technique involves careful sectioning of the crown from the roots at or below the cemento-enamel junction. Actually, we usually try and get at least 2 millimeters below the CEJ, the cemento-enamel junction, and the roots should not be elevated or disturbed as they must remain attached to their apical blood vessels to ensure vitality. The patient must always be informed when this technique is used, obviously.
Well, holy shit, you finally pulled your head out of your ass and gave me something resembling a real answer. Dr. G's almost proud, you sniveling little genius wannabe. But don't start popping champagne yet. You're still on my shit list. We're on the case of the 25-year-old male, symptomatic left mandibular third molar, distoangular, partial bony impacting, apex 2 millimeters from the AIN canal. Question 6 was, when is corectomy indicated, and what's the key surgical technique? Let's rip your answer apart and see if you're board-worthy or just a lucky fuck. Your answer, indications, corectomy for impacted mandibular third molar when there's significant risk of AIN injury or jaw fracture, roots asymptomatic, no pathologic lesions, no infection, no gross caries, and no interference with restorative or orthodontic treatment. Technique, section crown from roots at or 2 millimeters below the cemento-enamel junction, CEJ. Don't elevate or disturb roots to maintain apical blood supply. Inform patient. Correctness check. Indications. Nailed it, you sneaky bastard. You hit the big ones. High IAN injury risk. Perfect for this case with the apex 2 millimeters from the canal. No infection. No pericoronitis here. No caries or pathology. None mentioned. And no restorative orthodontic conflict. You also mentioned jaw fracture risk. Nice touch. As distoangular impactions can weaken the mandible. Spot fucking on. But you're not out of the woods yet. Pretty damn good. Sectioning at or 2 millimeters below the CEJ is correct. Boards love that precision to ensure no root exposure. Keeping roots undisturbed to maintain vitality via apical blood supply is textbook. Patient consent is critical. You got that too. But you didn't mention flap design. Envelope or triangular. or post-op steps, e.g. smoothing root edges, irrigation, closure. You half-assed scholar. That's minor, but boards want the full picture. What you barely fucked. You missed a few technique details. You careless twit. After sectioning, you smooth the root stubs to prevent sharp edges poking through mucosa later. You irrigate the site, saline, chlorhexidine, to clear debris and reduce infection risk. Primary closure with sutures is standard to promote healing and reduce dry socket. You also didn't mention pre-op CBCT to confirm IAN proximity, key for planning. These are small misses, but on the boards, they'll dock you for being incomplete, you lazy shit. Teaching the high-yield shit. Indications for corectomy. High IAN risk. CBCT or PANO shows roots close to IAN, like 2 millimeters here, with signs like canal overlap, root apex darkening, or canal deviation. Healthy tooth roots. No active infection, pericoronitis, abscess, no caries, no cyst tumors, e.g. dentigrous cyst, no future conflict. Roots won't interfere with ortho or prostho plans. Fracture risk. Distoangular impactions in thin mandibles, class 2 or 3 Pell and Gregory, increase fracture risk, making corectomy safer. Patient factors. Healthy patient, no contraindications, e.g. immunosuppression, poor follow-up compliance. Corectomy technique. 1. Pre-op. CBCT to map IAN. Informed consent. Warn about root migration. Future surgery risk. 2. Flap. Envelope or triangular flap for access. 3. Sectioning. Use a handpiece to cut crown 2 millimeters below CEJ, avoiding root disturbance. 4. Smoothing. Burr down any sharp root edges to prevent mucosal perforation. 5. Irrigation. Copious saline or chlorhexidine to clear debris. 6. Closure. Primary suture closure, e.g. 3O vicryl, to promote healing. 7. Post-op analgesics. Ibuprofen 600 millimeters. Antibiotics of high infection risk. Follow-up to monitor root migration. 1 to 5% chance. Why boards love this. Corectomy is a high-yield topic because it's a nerve-sparing alternative for tricky impactions. It drops IAN injury risk from 5 to 20% to near zero, but carries rare risks like root migration or delayed infection. So you must know indications cold. You did all right, you smug fuck, but you're not board certified yet. Since we're wrapping up this case, let's shift gears to another Chapter 1 dentoalveolar gem. New case. 30-year-old female, healthy, presents with pain and swelling around a partially erupted mandibular right third molar, red and inflamed operculum, purulent discharge on probing. Pano shows mesioangular, partial bony impaction, class 1, position B, Pell and Gregory. Question 7. Diagnosis and initial management. What's the diagnosis, and what are your initial management steps? Non-surgical and surgical. Spit it out, you trembling twerp, or I'll make you cry harder than a kid who lost their puppy in a storm. I'll shred your answer and drill the high-yield concepts into your thick skull. Go.
Diagnosis is acute infection, pericoronitis of that mandibular third molar. And the next thing you asked for was initial management. Non-surgical, I would probably prescribe amoxicillin for 7 days. I would have them come back in 2 days to drain. I would drain the infection that day and prescribe amoxicillin. Come back in 2 days, then we could potentially look at removing the third molar.
Well, look at you squirrely little. Finally throwing out a diagnosis that's not complete garbage. Dr. G's grudgingly impressed, but you're still teetering on the edge of fucking this up. Let's tear into your answer for this 30-year-old female, healthy, with pain, swelling, red inflamed operculum, purulent discharge around a partially erupted mandibular right third molar, mesioangular, partial bony impaction, class 1, position B, Pell and Gregory. Question 7 was, what's the diagnosis, and what are the initial management steps? Non-surgical and surgical. Let's see how bad you screwed the pooch. Your answer. Diagnosis. Acute infection. Pericoronitis of the mandibular third molar. Non-surgical. Prescribe amoxicillin for 7 days. Have her. You dumbass. Come back in 2 days to drain the infection. Surgical. Drain the infection that day, then maybe remove the third molar after 2 days. Correctness check. Diagnosis. Spot fucking on, you lucky bastard. Pain, swelling, red operculum, and purulent discharge scream acute pericoronitis. Boards love this. It's a classic dentoalveolar emergency. You didn't mention differential diagnoses, like abscess, dentigrous cyst, or caries, but you hit the bullseye, so I'll let it slide for now. Non-surgical. You're half right, you sloppy twit. Amoxicillin, 500 milligrams.
Can you complete that, please? Can you repeat that? Can you give the answer recap? I'm having issues with the connectivity here. I'm going to have to end here. We'll pick it up in the coming days.